this section, we'll be discussing the metabolism of heme. Remember that heme is the prosthetic group of hemoglobin, and heme carries that iron molecule which is responsible for carrying oxygen in red blood cells. Now, heme consists of that ferrous iron, the Fe2+, which is bound by a complex ring that we call a porphyrin ring. The particular porphyrin ring that holds iron is called protoporphyrin 9. Now, heme synthesis, as you can imagine, is a very complicated multi-step process. We're just going to consider a couple of steps. The committed and regulated step, rate-limiting step, is the condensation of succinyl-CoA, which you can remember comes from the TCA cycle, with the amino acid glycine. The resulting compound is called 5-amino-lemulinic acid, or ALA. Now, this reaction occurs in the mitochondria and is catalyzed by an enzyme called ALA synthase. ALA is then transported out of the mitochondria into the cytosol, where several of the steps of heme synthesis occur. And finally, the precursors are transported back to the mitochondria for the final two steps. And we're not going to detail those. I just want you to know that one step. Now, heme synthesis needs to be regulated because you don't want to produce more heme than you have hemoglobin. And so in both the liver and the bone marrow, free heme represses the formation of ALA synthase, so it blocks the translation of that protein. It also inhibits the transport of the formed protein into the mitochondria where it does its work. In addition to that, in the red blood cell precursors in the bone marrow, free heme promotes the synthesis of globin protein. And so this ensures that the synthesis of heme and the synthesis of globin are coordinated, that you're making the same amount of globin as you are heme, and you don't have an excess of one or the other. Now, there are lots of defects in heme synthesis that cause a constellation of diseases, the prototype of which we'll describe in the following clinical vignette. A 21-year-old woman presents to her physician complaining of abdominal pain, diarrhea, and dysuria. You begin a workup for infectious diarrhea and urinary tract infection, but while examining her, she also mentions that she's been hearing voices and that her fingers are tingling. She admits that she's had several of these episodes each year since puberty, but has never sought medical attention. The episodes usually occur during her menstrual periods. Physical exam is significant for tachycardia, a pulse of 120, but her other vital signs are normal. Her abdomen is mildly distended with diffuse mild tenderness to palpation without peritoneal signs. The pelvic exam is normal. CBC and electrolytes are normal. Her urine is dark red, but her routine urinalysis is normal. This patient has a disease called acute intermittent porphyria, or AIP. AIP is an autosomal dominant disorder caused by a defect in the third step of heme synthesis, the uroporphyrinogen 1 synthase, or porphobilinogen deaminase. And this is a liver that's found in the cytoplasm of liver cells. And you can see it illustrated here. Here's ALA synthase, which is the committed step. There's a second step which forms porphobilinogen, and then this is combined to form a long chain of these things, which are then brought together to form the ring that we see in porphyrin rings. The symptoms in this disease usually occur as intermittent attacks after puberty. They're much more common in women than in men, and they especially occur during menstruation, suggesting that there's some hormonal influence to the disease. The symptoms are variable, and not every patient gets every symptom, and not every symptom occurs every time, but they include things like severe abdominal pain with diarrhea or constipation or dysuria. They get muscle weakness and sometimes paresthesias, tingling in the extremities. They may have mental disturbances, which may be as simple as insomnia or as complex as hallucinations and paranoia. They can also have respiratory paralysis that can lead to death. This is a very, very rare complication of the disease, but occurs in some cases. The symptoms are thought to be caused by the toxic accumulation of ALA and of porphobilinogen. These compounds can be found in the urine, and because they're pigmented, when the urine sits for a while, it turns into this red color, especially if it's exposed to sunlight. Now, these acute attacks can be precipitated by infection, by poor nutrition, as I indicated, by hormonal changes, or by certain drugs such as barbiturates, sulfonamides, or alcohol. Treatment of this disease is symptomatic, narcotics for pain, and for some reason a high caloric intake seems to increase the excretion of porphobilinogen, somewhat relieving the symptoms. The patient should be counseled to avoid the things which precipitate the attacks, like alcohol or something like that, and seek prompt medical attention when the attacks occur because of this rare threat of respiratory failure and death. Now, there are a bunch of other porphyrias, in addition to AIP, that are caused by other defects in different steps of mitochondrial heme synthesis and cytosolic heme synthesis, and those are listed here. We'll cover just a few of these in detail. Variegate porphyria and hereditary coproporphyria are very similar to AIP. The only additional thing is these people tend to have photosensitive skin lesions. They have rashes that occur on sun-exposed skin. Porphyria cutanea tarda, erythropoietic porphyria, and congenital porphyria are non-acute, and individuals with these diseases have mostly just the photosensitive skin lesions. They have rashes that appear when they're exposed to the skin. These lesions are erythematous, they're bullous, which means blister-forming, or urticarial, meaning itchy lesions, which occur on the sun-exposed skin. If they're severe, they can lead to scarring and cosmetic defects. All of these things are the consequence of the accumulation of porphyrin intermediates, which are irritating to the skin, especially when they're converted to more irritating substances by UV irradiation, which is why these mostly occur on sun-exposed skin. Now, lead poisoning also leads to a defect in this process. Lead poisoning inhibits ALA dehydratase, which is the second step in heme synthesis, and this results in anemia, as well as other symptoms, including neuropathies and developmental delays and so forth. Urine ALA levels are increased owing to a blockage of its metabolism, and so the detection of increased levels of ALA in the urine is one way that you can detect lead poisoning. So here's a summary of the heme synthesis pathway. The inputs are glycine and succinyl-CoA. With iron, the output is heme. The key enzyme is ALA synthase, which is negatively feedback regulated by free heme. The associated disease is acute intermittent porphyria, as well as the other porphyrias, which are caused by deficiencies in the heme synthesis pathway. AIP, in particular, is caused by a deficiency in porphobilinogen deaminase. Okay, so we've synthesized heme. Now, how do we degrade heme? Now, the catabolism of heme generally occurs in the liver and the spleen, where old red blood cells are ingested and broken down. Remember, the red blood cells live for about 120 days, and then they start to fail. They're ingested by macrophages in the liver and the spleen, and they're broken down. One of the things that those macrophages have to do is they have to degrade the heme into something that can be excreted. Now, the first thing that happens is that heme is degraded to bilirubin by the enzyme hemin oxygenase, which is indicated right here. So we take hemoglobin, we break it down into biliverdin, and then that's converted to bilirubin. Now, bilirubin is a fairly insoluble compound, and so bilirubin needs to be conjugated to something more soluble in order for it to be excreted. And so what happens is we conjugate it to a couple of glucuronide molecules, which are sugars that are very hydrophilic and increase the solubility of bilirubin. This conjugation takes place in the liver, and the enzyme responsible for it is uridine diphosphate glucuronal transferase, or UGT. This conjugated bilirubin is then able to be excreted in the bile. Now, once it's in the bile, it gets to the intestine, and intestinal bacteria convert the bilirubin to urobilinogen and to stercobilin. Urobilinogen is then reabsorbed and can be excreted by the kidneys. Bilirubin and stercobilin are what gives feces their brownish color. So anybody that has a bile duct obstruction in which the bilirubin metabolites are not getting into the intestinal tract, their feces will be chalky white, and that's a sign of bile duct obstruction. Now, any accumulation of bilirubin in the plasma is called jaundice. Now, remember, bilirubin is a pigmented molecule, and so the accumulation of bilirubin in the skin and in the plasma results in yellow discoloration of the skin and the sclera. This is what we refer to as jaundice. Jaundice can be due to a conjugated or direct hyperbilirubinemia. This is where the jaundice is due to accumulation of bilirubin which has already been conjugated, or it can be caused by an unconjugated hyperbilirubinemia or indirect hyperbilirubinemia. This is accumulation of bilirubin that is unconjugated. Now, hepatic damage from hepatitis or cirrhosis or something like that can cause both a conjugated and an unconjugated hyperbilirubinemia. Now, there are a couple of things that can cause conjugated hyperbilirubinemia syndromes. Remember that in order to have a conjugated hyperbilirubinemia, you have to be able to conjugate the bilirubin, but you can't get rid of the bilirubin once it's conjugated. So one of the things that will cause this is intra or extrahepatic bile duct obstruction of any cause. It could be choledocholithiasis, it could be a tumor obstructing the duct, it could be primary sclerosing cholangitis, and so on and so forth. What happens in this case is the bilirubin is conjugated, but it's not able to be excreted, and so it ends up in the blood where it causes jaundice. Now, there's a couple of congenital defects called Dugan-Johnson syndrome and Roeder syndrome that are actually genetic defects in the transport of conjugated bilirubin into the bile canaliculi, and that'll cause conjugated hyperbilirubinemia as well. Unconjugated hyperbilirubinemia is caused in situations where you're unable, the conjugating system is either not present or is overwhelmed. In hemolytic anemia, for example, you have a large overproduction of bilirubin because of all the red blood cells that are dying. This overwhelms the capacity of the conjugating system, and you end up with accumulation of unconjugated bilirubin, leading to jaundice. That's why individuals with hemolytic anemias will often be jaundiced. Neonatal jaundice is a jaundice that occurs early in life before the conjugating system is fully developed. And so babies in the first week or two of life sometimes will have a little bit of jaundice as a result of not being able to conjugate the bilirubin fast enough. Now again, there's a couple of genetic syndromes in which the conjugating enzyme, UGT, is actually defective. And these are the Crigler-Najjar syndrome and Gilbert syndrome, which are covered more in the pathology lectures. So here's a summary of heme degradation. The input is heme, the output is bilirubin, which is converted in the intestine to urobilinogen, then excreted in the kidneys, and also stercobilin. The key enzymes are hemin oxygenase, which is the first step, and uridine diphosphate glucuronidase, or UGT. The associated diseases are all the forms of jaundice that we talked about. And this ends the section on heme metabolism.